Okay, so I guess we'll go ahead and get started. I'd like to echo my thanks to everyone who has decided to join us for this brief presentation. I would like to say that what I'm going to do is a relatively broad overview of what's in the new blood pressure guidelines, because I wanted to leave time for questions that people might have, and can certainly go more in depth in particular issues that folks want to ask about. So I wanted to start with a little bit of background. The last time the blood pressure guidelines for children was updated was in 2004. So you can see that had been a long time before these new ones came out in 2017. These were developed by the American Academy of Pediatrics and their Council on Quality Improvement and Patient Safety. And I think one of the things that's important to note is that they are endorsed also by the American Heart Association. Like so many things in pediatrics, these recommendations or guidelines are based on a combination of evidence and expert consensus opinion. As you know, a lot of times we don't have the research to always back up what we do in peds, and so when there wasn't enough research evidence, it was based on the consensus opinions of the experts who were part of the panel. So there are 30 key action statements. I am not going to go through all 30 of those key action statements or the 27 additional recommendations, but I will highlight some of the specific key action statements. And for those of you who have the reference, if there are others that you want to touch on or ask about at the end, please feel free to do so. And I thought I would summarize the changes, and then I will go into more detail on some of these, although not all of these, as we go through the rest of the talk. One change was that the term pre-hypertension has been dropped and changed to elevated blood pressure. And, you know, I've certainly, in talking to various people, heard mixed responses to this. There are some people who think it's a good thing, and there are some people who think that it makes it more confusing. The rationale given in the paper is that they thought pre-hypertension sounded too vague, too nebulous, but if you tell somebody that their child has elevated blood pressure, it is thought to hopefully stimulate them to want to take some action, that there actually is a problem rather than saying it's pre-hypertension. The other thing that's different here, and I think one of the more important differences from the old guidelines, is that the tables that you see in this new set are based on normative blood pressures from normal weight children. The old tables actually included children who were overweight or obese, and since we know that overweight and obesity themselves are associated with hypertension, it was felt that it wasn't appropriate to include those children in designing these tables. So the result of that, of course, is that now the normal blood pressures are lower than had been in the old tables, almost akin to what you've seen come out for adults now. Instead of 140 over 90, it's now 120 over 80 for adults. There is in the guidelines a simplified screening table, which I will show you and talk a little bit about in the next few slides. There's a simplified classification for adolescents. So even though when you go into the detailed table, there are numbers for ages 13 through 17 individually, for the screening table, they simplify it to one blood pressure level for adolescents that would require investigation. And so we can then expand on that. And that simplified classification actually is in line with the adult numbers. that I mentioned previously. They talk more in terms of the timing of screening for blood pressure measurements, so it's not every encounter that you have with the child except under certain circumstances. They've streamlined the recommendations for how you do the initial evaluation and management, which I will talk about, and expanded a role for ambulatory blood pressure measures. So I know that that may not be available to everyone, but there are certain cases in which ambulatory blood pressure measures are felt to be particularly helpful. And they've revised the recommendations for echocardiography, which I'll touch on only briefly unless there are questions. So some of the key action statements that I wanted to highlight. One is this diagnosis of hypertension and the fact that it needs to be confirmed by auscultatory blood pressure measurements and not the oscillometric devices. And it's got to be 3 different visits. So you wouldn't make this diagnosis on a kid that you saw once that had an elevated reading. You want to repeat it at that visit, and then you want to repeat it at 2 additional visits. The oscillometric devices that are validated in children are fine for screening, but if you get an elevated measure with those devices, then you want to confirm it by auscultation. The home blood pressure monitoring, it's recommended that those not be used to make a diagnosis of hypertension, and hypertension of any form, whether it's clinical hypertension, masked hypertension, or white coat hypertension. They can be useful in monitoring a kid that's been diagnosed and it's on treatment and you want to see what's going on, but that should not be the way they're diagnosed. And then in children who are diagnosed with hypertension, if you treat them, the idea is to get them to a systolic blood pressure and diastolic blood pressure that's less than the 90th percentile and the 130/80 in adolescence. Again, just as a general guide, you can hone that in for the particular adolescent based on their actual age, their height percentile, and their sex. Lifestyle modifications are generally the way to start, but if those fail, then if you're going to start pharmacologic treatment, the classes of drugs that are recommended are either ACE inhibitors, the angiotensin receptor blockers, or ARBs, long-acting calcium channel blockers, or thiazide diuretic. And in adolescents who have elevated blood pressure or hypertension, the recommendation is that their care is transitioned to an adult provider by age 22. So let's talk a little bit about hypertension and elevated blood pressure themselves. Clinical hypertension is thought to have a prevalence of about 3.5% of children and adolescents. And somewhere between 2.2% and 3.5% have persistently elevated blood pressures. Those numbers are higher in overweight and obese children. And it's important to assess these kids because higher blood pressures in childhood correlate with higher blood pressures in adulthood. And there's a lot of data and a lot of research going on now in terms of the whole issue of childhood precursors of adult disease, and certainly hypertension is one of the big ones. In specifically children who are overweight or obese, the prevalence of hypertension is between 3.8% and 24.8%. And what's seen is that it increases in a graded fashion. So the more overweight or more obese the child is, the higher the likelihood that they will have hypertension. And obesity itself, even in a child who's not hypertensive, but if they're obese, it's shown to be related to development of future hypertension as they get into young adulthood and later. Other things to keep in mind with children who are overweight and obese is that you can see dyslipidemia as well as disordered glucose metabolism in this group. So you need to look at additional comorbidities in kids who are overweight or obese. So here are the updated definitions and categories that I took directly from the publication. This is Table 3 in the publication. Normal blood pressure, that definition for children age 1 to 13 hasn't changed. It's less than the 90th percentile. What's different is the normal blood pressure there for adolescents with a guide that normal should be less than 120 over less than 80. And then you can see elevated is between the 90th and 95th percentile in the younger age group. Stage 1 hypertension is above the 95th percentile until you get to 12 millimeters of mercury above the 95th percentile. And then stage 2 is anything higher than 12 millimeters of mercury above the 95th percentile. The more simplified version for the adolescents is, to give a specific range, elevated being 120 over less than 80 to 129 over less than 80, stage 1, 130 over 80 to 139 over 89, and stage 2, above 140 over 90. Key to making the diagnosis of hypertension is appropriate measurement. You need to be able to accurately measure the child's blood pressure, and that means having a variety of cuff sizes available. You verify the cuff size that you need by measuring the mid-arm circumference, and there's a nice diagram in the publication that I meant to include in here and forgot, I apologize, that shows how you determine where to measure the mid-arm circumference and know that you have the correct cuff size. As I mentioned before, you need more than one measurement. Usually if a kid comes in and sits and you take a pressure, if you repeat it a couple of times, it usually decreases with repeated measures. Again, to emphasize, your initial measurement may be oscillometric, but you need auscultation to confirm. And there's this nice flow chart that goes over that, again, that's directly from the publication. So you want to seat the child, let them rest, relax for a few minutes. Things like their feet should be on the ground, their arms supported, etc. And if you measure it and the blood pressure is above the 90th percentile, you then remeasure it twice and average these. If it's not, then they have normal blood pressure. Once you average your two additional measures, if the average is not above the 90th percentile, then again, we're back to normal blood pressure. But if the average is, you want to know, were those repeat measures auscultatory or not? If they weren't, then you do it twice again by auscultation, average those, and again, greater than the 90th percentile, you would classify their blood pressure according to what I showed you previously, and if it's not, then they have normal blood pressure. So here's the simplified screening table. Again, to make the diagnosis for an individual child, you'll need to look at the full tables, which I do not include in my slides because it's pages and pages of readings for ages 1 through 17 and for different height percentiles and then the different blood pressure percentiles. But the idea behind this simplified table is that if you have, for example, a little boy who comes in who's 4 years old, anything in this 102 over 60 range would prompt you to look further, and then you can pull out the tables and look for the specifics based on his height percentile to determine where where they fall in terms of classification. But this is just meant to be a quick guide to eyeball and say, okay, they're nowhere near this range, so it's probably not something to be concerned about. The recommendation is that in healthy children, you should measure their blood pressures annually starting at age 3. But if they have any of these other issues, they're obese, they have kidney disease, diabetes, coarctation of the aorta, or they're on medications that are likely to increase their blood pressure, the recommendation is that you check it at every health encounter, not just annually. Now, there are times when you need to measure blood pressure in children who are younger than 3 years, and this is quite an extensive list. One of the key issues is someone with a history of prematurity. We now know through a lot of research that prematurity and small for gestational age, very low birth weight infants, have a risk of being hypertensive. Certainly, a child who had been in the neonatal intensive care unit and had an umbilical artery line needs to be followed very carefully for development of hypertension. And then the list goes on: congenital heart disease, recurrent urinary tract infections, known renal disease, family history of renal disease, a child who's had a solid organ transplant, bone marrow transplant or some type of malignancy, again on meds known to increase blood pressure, any systemic illness, and if they've had any evidence of elevated intracranial pressure. So just be mindful that any child who has any of these, even if they're less than 3, you need to measure their blood pressure. Healthy kids, you can start measuring it at age 3. So what are some of the common medications that can be associated with high blood pressure in children? You see here lots of over-the-counter drugs, particularly decongestants, the non-steroidal anti-inflammatories, some herbal meds and nutritional supplements. And then there are a lot of medications that we as physicians prescribe that have the potential to have elevated blood pressure as a side effect. The stimulants for ADHD, hormonal contraception, antidepressants, corticosteroids, and then, of course, illicit drugs like amphetamines and cocaine. So you have to be mindful of these and ask the question in terms of what the child is taking. As you all probably know, a lot of times when you ask particularly parents or teenagers about medications, they tend to tell you about what's been prescribed, and you have to often specifically ask about over-the-counter medications. And certainly in the adolescents, you want to be certain to ask about illicit drug use. So how do we screen? The general recommendations, and these are coned down a lot from what was in the 4th report. So the recommendation is that for all patients who you determine have hypertension, you want to check a urinalysis and a chemistry panel and kidney function. Get a lipid profile. It can be fasting or non-fasting. It's not as big a deal as in adults that it has to be fasting. Renal ultrasound in the younger ones or in anybody who's got an abnormal urinalysis or abnormal renal function. And then specifically if you're dealing with a child who is obese, meaning their BMI is above the 95th percentile, you want to check a hemoglobin A1C to look for diabetes or prediabetes. Check their liver function test because you want to look for evidence of a fatty liver, and then in this case you want to do a fasting lipid panel to look for dyslipidemia. And then based on your physical exam and the results of those initial tests that were done and the history that you get in terms of family, sleep, etc., you can then get some optional tests that are more specific. So if you think that there's a high risk for diabetes, you want to get a fasting serum glucose. If there's evidence that there may be a thyroid issue, check thyroid stimulating hormone. The drug screen, as I said, you have to be sure to ask about illicit drug use, and certainly even if the answer is no, if you suspect that that's a possibility, a drug screen would be a reasonable thing to do. Sleep studies, if you get a history that this child snores or they're sleepy during the day or have some history of apnea, a sleep study is an important test to do. And if you have any evidence that there may be abnormal renal function or growth delay, then a CBC is a reasonable thing to do. So you can see a CBC is not recommended as a screening test for everybody, but just under specific circumstances. So how do we manage these children? If you determine that it's elevated blood pressure but not stage 1 or stage 2 hypertension, lifestyle interventions, and then recheck them in 6 months. If it's still elevated and you hadn't done a lower extremity blood pressure on a previous visit, now would be the time to check lower extremity blood pressure, repeat the lifestyle counseling, and then have them come back in 6 months again. If they're still elevated after 12 months, the next step would be to get the ambulatory blood pressure measurement and do a diagnostic evaluation. You can consider a subspecialty referral at this point, but it's certainly not absolutely necessary. And then if their blood pressure normalizes after you've checked them over this time, you can just go back to their regular annual screen. If they actually have hypertension, stage 1 hypertension, again, you start with the lifestyle counseling. This time, though, you would recheck them in 1 to 2 weeks with an auscultatory blood pressure. If they're still stage 1 at that recheck, and again, if you hadn't done a lower extremity blood pressure before, you would do it at this point. Recheck them in 3 months. Consider nutrition and weight management referral if you determine the child is overweight and needs those types of interventions. And if their blood pressure is still unchanged after 3 visits, do the ABPM, do the diagnostic evaluation, and probably consider referring them for subspecialty evaluation at that point. And of course, this is going to vary depending on your level of comfort in dealing with and treating hypertension. For people who feel comfortable managing these kids themselves, you can move on to treatment if you're comfortable with that, and we'll talk about treatment options. For those who are stage 2 hypertension, clearly there is more urgency here. So you want to check their upper and lower extremities. The lifestyle recommendations are always there no matter what stage of hypertension. You want to recheck them in a week, or you can go ahead and refer them to a subspecialist in a week. If their repeat is unchanged, you want to do their diagnostic evaluation within a week, including the ambulatory blood pressure measurement, and start treatment or refer them to a subspecialist at that point. For those who are symptomatic, or if their blood pressure is more than 30 millimeters of mercury above the 95th percentile, you need to send them to the emergency room to have some type of urgent treatment initiated. So kids who are at this level, you're not going to sit on it and have them come back, especially if they're symptomatic. So what do we mean by lifestyle changes in terms of the initial treatment? Diet is a big one, and the diet that's recommended specifically is the DASH diet, which is high in fruits and vegetables, low-fat dairy, whole grains, fish, poultry, nuts, and lean red meats. You also want to recommend that they have moderate to vigorous physical activity for half an hour to an hour, at least 3 to 5 days per week. If they're obese or overweight, you want to work on weight loss. And one of the things that's often overlooked is the need for stress reduction. There are a lot of things that, as we know from research and from what we hear in the news, that cause stress now in children. And so you would want to make sure that those issues are addressed as well, and you know, that they're not dismissed out of hand as not important. We now know that they actually can be quite important. The pharmacologic interventions we recommend if lifestyle intervention doesn't work, or if the child is symptomatic, and as I mentioned, certainly if they're at stage 2 hypertension, and certainly if they have concomitant chronic kidney disease or diabetes mellitus. You start a single medication at the low end of the dosing range and then increase it every 2 to 4 weeks until the blood pressure is controlled. Once you have maxed out that single medication, either by the recommended dose or certainly if the child is having side effects from that, you want to add a second agent and titrate it in a similar way as you did with the first agent. I mentioned early on that one of the key action statements was to start either an ACE, an ARB, a long-acting calcium channel blocker, or a thiazide diuretic. And in children who have chronic kidney disease, diabetes, or proteinuria from any reason, your first line should always be an ACE or an ARB. So how do we monitor to know if these things are working? If it's somebody with elevated blood pressure and you're doing lifestyle changes only, you can follow them every 3 to 6 months. We know it takes time for those lifestyle changes to have an impact. You're not going to expect, to see a significant weight change, for example, in just a couple of weeks. So you would want to wait 3 to 6 months. If it's a child that you've put on a pharmacologic agent, you want to check them every 4 to 6 weeks for the dose adjustments. Once the goal is achieved, you see them every 3 to 4 months. Here is where home BPs can be useful in terms of helping to figure out how well controlled they are when they're away from you. And of course, this is assuming adherence, which is a whole nother topic that we could have on another day. If it's a child, particularly with chronic kidney disease, you can recheck the ambulatory blood pressure monitoring as well to gauge how well your treatment is working. And I mentioned already the assessment for adherence and, of course, any adverse effects. The adverse effects could be the reason for non-adherence, for example, and if we don't specifically ask, we won't have that information. So overall, why is this important to diagnose and prevent hypertension? I mentioned earlier that elevated blood pressure in childhood increases the risk for adult hypertension. And there are data that show that adolescents with an elevated blood pressure progress to hypertension at a rate of about 7% per year. So not an insignificant problem. It's also known that adult cardiovascular disease likely has its origins in childhood, so anything we can do at our end to either prevent or treat hypertension in the pediatric age range will hopefully go a long way in protecting these children when they get into adulthood from developing cardiovascular disease. So I'm going to wrap up with these take-home messages, and then I'm happy to take questions. You want to measure the blood pressure annually starting at age 3, unless otherwise indicated in that list that I showed you. Have varying cuff sizes available. The kids come in different sizes, and so the cuffs need to as well. Blood pressure classification is based on age, height, and sex, and that's something that has not changed since the fourth report. Generally, we start with lifestyle changes, medication if the lifestyle changes fail, or if the child is symptomatic or has kidney disease or diabetes, and refer to a subspecialist as needed. As I said, some of you will have different levels of comfort with taking care of children with hypertension, but we're certainly here and available if you have questions and feel the need to refer them for treatment. And so I will stop there and happy to field questions.
So I have a quick question.
Yes.
Can you hear me? Okay.
Yes, I can.
So in your screening test for those, sorry, my name is Jessica Petros. I'm a med-peds provider.
Okay.
In the table that you had shown about the screening tests to do once a child is diagnosed with hypertension, you had listed under all patients the renal ultrasound, but it looks like it's not all. Is it just for those everyone less than 6, or if they have those abnormal lab findings, or is it for all patients? It seemed to have a little caveat, so I just wanted to verify.
Yeah, so the caveat, and I lifted this table directly out of the publication. And so, yes,
Okay.
it's for those who are less than 6, or if they have an abnormal urinalysis or renal function. So it's just something for you to consider in patients in general. So they're just talking about the general screening.
And would you continue, would you do annual urinalysis? As in adults, the Renal Association recommends, although the USPSTF doesn't necessarily, it's a gray area at the moment. So in adults, though, that's definitely a consideration. I don't know, on peds, would you continually, periodically do a UA?
I mean, the AAP doesn't recommend it annually for kids. Of course, I see a group who are at risk, so of course we do UAs on them all the time. But I know the AAP doesn't recommend in otherwise healthy kids that you do the urinalysis annually. They recommend it at very prescribed times. And so, yeah, it's not an across-the-board thing for peds.
Right. So I figured probably because hypertensive nephropathy would take, reason we do it in adulthood, but the pediatric, I also don't do it very often, so I'm just trying to finesse that.
I mean, if you're talking about a kid that's hypertensive, then
yes, that's
I would recheck the urinalysis. Sorry, I thought you meant in general. Yeah, so if they're hypertensive, yes, I would repeat the UAs.
And you do a UA or microalbuminuria or a UA? Sorry, it's a lot of questions.
No, that's fine. So there are data out there, and they actually touch on this in the guidelines as well, that there are data that show that microalbuminuria could be a marker of hypertension-related kidney injury. But the data is in adults. There's really not a whole lot in children that shows the same thing. In fact, microalbuminuria can be kind of non-specific in children, and you can even sometimes see it without hypertension. But I think certainly if you're talking an older adolescent, microalbuminuria is not an unreasonable thing to do.
Okay. Thank you.
You're welcome. Other questions? The one thing one of the things I didn't talk about is certainly in the neonates. There are a whole different set of tables for assessing neonates, and what these new guidelines say is to use the old tables that were in the prior report. There are a couple of references in the new guidelines that tells you where to find the tables for neonates, as well as where to find the tables for older infants up until a year of age, because as you can see from these guidelines, the recommendation and the blood pressure tables start at age 1. So if you've got a younger child, there are a whole different set of tables to look at. And then I discovered that there's actually an app that you can put on your smartphone that you can plug in the child's age and blood pressure, or age and height, and it'll tell you what the percentile should be. So if you've just got your phone in your pocket and you're seeing the kids, you can put it on there. And I have no stock in whatever the company is that has that, but I just recently learned about that app. No other questions?
I have a question. Is the upper and lower extremity blood pressure readings recommended across all ages or just for the younger pediatric group?
For all ages, if they are, certainly if you on repeat check their blood pressure is elevated or they're hypertensive, it's recommended that you check it. And you just need to check one lower extremity. You don't actually have to check both. Any other questions? If not, thank you very much for joining us. And as I said, we're certainly available here in the nephrology division to address questions that you may have with your patients with hypertension, and we're certainly happy to see them if you feel they need referral.